The last class, DIC. Then let's start. First, let's review DIC. The last class we have learned definition of DIC, etiology, now pathogenesis, and triggering of DIC. Now you might remember. First, definition. Etiology, activated coagulation system, thrombin increase, solely to coagulation function increase for microthrombus in microcirculation. Because of forming microthrombus, so coagulation factors and platelets are consumed. So coagulation factors and platelets decrease, coagulation function decrease. Now fibrinolytic system is secondary activated. Plasmin increase also lead to coagulation function decrease. Coagulation function begin to decrease. What happen? Bleeding or clot? Happen bleeding. So bleeding. Now pathogenesis not so lead to manifestation. What manifestation of DIC? Because bleeding. Now, so the patient may be hyper shock, organ dysfunction. Now, also happen. Now, bleeding, shock, organ dysfunction, and hemolytic anemia, a red blood cell break. So manifestation of DIC include 4: bleeding, shock, organ dysfunction, and hemolytic anemia. From definition, we know DIC is imbalance of coagulation and anticoagulation, not coagulation function increase, not only coagulation function decrease. It is imbalance. Now, etiology of DIC include 4. Infection, malignant tumor, obstetric complication, operation, and trauma. From it, now, what is the most common etiology of DIC? Infection. From it, we know which types shock maybe happen DIC early or easy. Infection shock and traumatic shock. Now, obstetric complication because now tissue factor enter the blood. Tissue factor. Now, disseminate placenta. Disseminate placenta can release a lot of tissue factor. So obstetric complication maybe lead to DIC because tissue factor can stimulate intrinsic coagulation pathway. So the disease can lead to DIC. Now it is etiology of DIC. The second, pathogenesis of DIC also include 4. The first, extensive tissue injured, so stimulate intrinsic coagulation pathway. Now damage of vascular endothelial cell lead to imbalance of coagulation and anticoagulation. Destruction of blood cell and activation of platelet. Now the last, procoagulants entering circulation. Now it is pathogenesis of DIC include 4. You might remember. What can damage VEC? Severe hypoxia, acidosis, antibody urgent, and infection, endotoxin can damage VEC. Damage VEC why lead to DIC? Why damage VEC lead to DIC? The pathogenesis include I5. The first, damage VEC can release tissue factor. Now, VEC is damaged, so collagen export. Now, stimulate coagulation factor 12. Stimulate intrinsic coagulation pathway. Now, the other three. First, damage VEC release PGI2, NO, and ADPase. PGI2, NO, and ADPase decrease. So vasoconstriction and platelet aggregation. Now the next, release antithrombin 3, release TFPI, tissue factor pathway inhibitor decrease, and release PI decrease. So anticoagulation function decrease. Now the 3 substances released by VEC. Now they belong to coagulation system or anticoagulation system. Anticoagulation system. So damage VEC release this decrease. So anticoagulation function decrease and the coagulation function increase. So maybe happen DIC. Now, normal VEC can release TPA and UPA. TPA, UPA belong to which system? Fibrinolytic system. It belongs to plasminogen activator. So if VEC damage, so release TPA and the UPA decrease. So fibrinolytic system stimulated or inhibited. Activator less, so inhibit. So inhibit fibrinolytic system. So also lead to coagulation function increase. Now the patient. So damage VEC can lead to DIC. The pathogenesis include 5. Now tissue factor. Now intrinsic coagulation pathway. Now 100 intrinsic coagulation pathway. Now the first, second, third, fourth, and the fifth. Now it is the pathogenesis. Now it is pathogenesis of DIC include 4. Now the second damage VEC due to DIC include 5. Understand? Now the next factor influencing of the development of DIC, triggering of DIC. Now include 4. Damage function of mononuclear fractile system. Mononuclear fractile system belong to cellular anti-coagulation system. Now impairment of liver function. Some coagulation factors depress in liver. Now hypercoagulable status of blood include acidosis, pregnancy, and acidosis. Now the 4, disorder of microcirculation. For example, shock, refractory state, plasma move out, viscosity increase, so red blood cell and platelet aggregation. Now maybe lead to DIC. It is triggering of DIC include 4. Now it is the last class we have learned. Now today we will learn DIC. Now the next clinical stage and classification. According the development of DIC is divided into 3 stages: hypercoagulable, hypocoagulable, and the secondary fibrinolytic stage. Now, DIC is divided into 3 stages. You might remember 3 stages and characteristic of every stage. Now you might remember. Now, from definition, we know during DIC, etiology must lead to coagulation function increase or decrease. Increase. Now lead to thrombin increase. Now so coagulation function increase. So it called the hypercoagulable state. Now during the stage, what happened? Form microthrombus. Now the next, because forming microthrombus, so platelet and the coagulation factors consume. So they will less. So coagulation function begin to decrease. So the stage called the hypocoagulable state. Now during the stage, now what decrease? Coagulation factors and the platelet decrease. Coagulation function decrease. So form microthrombus or hyperbleeding. So from the second stage, hypocoagulable state, hyperbleeding. Now, because coagulation system is activated, we know the next which system also stimulated? fibrinotic system is stimulated. So the patient fibrinotic system stimulated. It stimulated, which will increase. Plasmin will increase. A function of plasmin can hydrolyze coagulation factors. Also, hydrolyze fibrin. What is fibrin? Fibrin refers to coagulation factor. Fibrin coagulation factor, how many? Fibrin refers to coagulation factor 1. Factor 2 refers to thrombin. 3 tissue factor, 4 calcium. Now, plasmin can hydrolyze fibrin. Now, you know, during the DIC, fibrin increase or decrease first. During the hypercoagulable state, now fibrin will increase. Now, when fibrinotic system is stimulated, so plasmin will hydrolyze fibrin. It hydrolyzes fibrin and form fragment. The fragment is called FDP, fragment degradation product, is called FDP. So during the secondary fibrinotic stage, what will increase? FDP will increase. What leads to FDP increase? Plasmin hydrolyze fibrin. It form FDP. Now FDP have anti-coagulation function. So during the stage, bleeding more or less? Bleeding more, because FDP have anti-coagulation function. Now the next we will learn the pathogenesis have anti-coagulation function. Why have anti-coagulation function? The next manifestation of DIC bleeding we will learn. During this, you know FDP have anti-coagulation function, so lead to bleeding more, severe bleeding. So during the secondary fibrinotic stage, bleeding more. Now it is 3 stages of DIC. You might remember 3 stages and the characteristic. Now during the hypercoagulable stage, because coagulation system is activated, so coagulation function increase and form microthrombus. Because of forming microthrombus, so coagulation factors and platelet decrease. Coagulation function begin to decrease, so not microthrombus and hyperbleeding. Now bleeding. Now the next fibrinotic system is activated. Plasmin increase. Plasmin also can hydrolyze fibrin and form FDP, so lead to bleeding. FDP have anti-coagulation function, so lead to bleeding more. So during the secondary fibrinotic stage, severe bleeding more. Now, if the patient of DIC hyperbleeding, now the patient must hypocoagulable state or secondary fibrinotic stage, and because the last stage happen bleeding. The first stage form microthrombus. Microthrombus, the doctors can see or can't see. Now can see microthrombus or can see microthrombus and can see bleeding, doctors can see. So manifestation of DIC, the first manifestation refer to bleeding, not microthrombus. Now it is stage of DIC, you might remember, it is emphasis, maybe solved question. Now the next, classification of DIC. According to the clinical cause, DIC is divided into acute, subacute, and chronic DIC. It is easy, you know it's okay. Now, if the DIC happen quickly, it is acute. Now slowly, it is chronic. If between acute and chronic is called subacute DIC. Now, acute DIC maybe occur within several hours or 1-2 days, happen quickly. Now, so acute DIC, for example, severe infection, trauma. Now, the manifestation maybe happen shock, bleeding. Now, subacute DIC occur within days or 2 weeks. Manifestation is not thrombotic manifestation. For example, tumor. Chronic DIC happen very quickly, very slowly, maybe several months. Now, manifestation slide. Malignant tumor, chronic hemolytic anemia, so such as. Now it is classification. Now, according to the compensatory level, now we know during the first stage, hypercoagulative state form microthrombus, coagulation factor and platelet are consumed. Now, the patient have compensation, so we are produce coagulation factors and platelets. According the produce and consume, so DIC is divided into 3 classifications. Now first, decompensatory DIC. We know decompensatory, so which more? Consume more or produce more? I consume more. So the patient coagulation factor will decrease. Now, what DIC can lead to compensatory DIC? Now, which type, which classification? Acute or chronic? Acute DIC. Acute DIC consume the more, produce production less. Now, so the patient have shock and bleeding. Now, compensatory DIC consume and production same. So balance between consume and production, coagulation factors and platelet. So the patient mild bleeding, proboscis. Coagulation factors is normal because it is balanced. So coagulation factors is normal. maybe chronic, or maybe chronic. Now, overcompensatory DIC production is more than consumed. Now, it is no compensation, no manifestation. Coagulation factor will increase. Now, maybe recover state of DIC. Now, it is classification. Classification and the state, you might remember 3 stages. State is emphasis. Classification, you know is okay. Now the next, alteration of metabolism and function. Now, manifestation. From the definition, we know DIC manifestation include for bleeding, organ dysfunction, shock, hemolytic anemia, macroalgiopathic, hemolytic. Bleeding is the first manifestation. DIC, the first manifestation, not microthrombus. We know microthrombus we can't see. So the first manifestation refer to bleeding. So what is the first manifestation of DIC? It is bleeding, not microthrombus. Now, why happen bleeding? Now the bleeding is the most manifestation. Now, maybe skin, mucosa, gastrointestinal tract, and pulmonary happen bleeding. Now, all the body maybe happen bleeding. Now, the bleeding may be slightly, maybe severe. Now, why happen bleeding? Now, from which stage happen bleeding? At hypocoagulable stage. So we know what lead to bleeding, because coagulation factor and the platelet consumed. Now, fibrinolytic. Now, the second fibrinolytic stage have bleeding or no? I have. Why? Because fibrinolytic system is activated, plasmin increase, so lead to coagulation function decrease, so happen bleeding. Now during the secondary fibrinolytic stage, produce FDP. What function FDP? Anticoagulation function. So FDP increase, also lead to bleeding. Now we know why happen bleeding. The pathogenesis. The first consumption of coagulation factors. Now it is the first coagulation factors and the platelet consumed, because during DIC, during the hypercoagulable state, form microthrombus. So coagulation factors and the platelet are consumed, so they will less. So happen bleeding. Now it is the first. Now refer to hypocoagulable state. Now secondary fibrinolytic system is activated. Now during the secondary fibrinolytic stage, the system is activated. Now, because during DIC, the first stage, coagulation system is activated. So also stimulate fibrinotic system. Now, why fibrinotic system? During DIC, why fibrinotic system is activated? Now, because intrinsic or extrinsic coagulation pathway is stimulated, so plasminogen activity increase. Intrinsic coagulation pathway. Now, coagulation factor 12, factor 2 belong to plasminogen activator. Now, so the patient fibrinotic system is activated. So, coagulation system is activated and produce plasminogen activator. So, the next fibrinotic system is activated. The system is activated, so plasmin increase, coagulation function decrease, so hyperbleeding. Now in the second pathogenesis, hyperbleeding. Now form form FDP. Now, what is FDP? Fibrinogen degradation product. Now, during DIC, because fibrinotic system is secondary activated. What is secondary fibrinotic activity? What is the first? Now, during DIC, it is called secondary fibrinotic stimulated. What is secondary? What is the first? Secondary refer to first coagulation system activated, and the next fibrinotic system is activated. It's called secondary because coagulation system first activated. If no coagulation system activated, now only fibrinotic system activated, it's called first fibrinotic system activated. Understand? Now during DIC, fibrinotic system is activated, belong to first or second. Second. During DIC, first coagulation function increase and form microthrombus. So during the hypercoagulable stage, coagulation system is activated. Now you must know, DIC first coagulation system activated, so coagulation function increase and form microthrombus. And the next fibrinotic system is activated, so it called secondary fibrinotic system activated. Now DIC, the FDP. Now DIC during the secondary fibrinotic system, plasmin increase. Plasmin can hydrolyze fibrin and fibrinogen and form degradation. The degradation is called FDP. Now FDP, we have no, it have coagulation or anticoagulation function. Anticoagulation function. Why it have anticoagulation function? Now the first, it can impair the platelet. So FDP increase platelet aggregation or not aggregation. Not aggregation. So FDP have anticoagulation. It can impair the platelet. Now the second, FDP can block fibril polymerization. So from FDP increase, fibril can form clot or can't form clot. Block fibril polymerization. Block fibril polymerization. So if FDP increase, fibril can't form clot. So FDP have anticoagulation function. Now it is FDP have anticoagulation function. Now, so during DIC happen bleeding. Now why bleeding is the first manifestation of DIC? Why happen DIC? The pathogens include three. First, what consume? Now, first refer to coagulation factors and platelet are consumed. So during the hypocoagulable stage, coagulation factor and the platelet decrease. Now, during the hypercoagulable stage, form microthrombus, so coagulation factors and the platelet are consumed. So during the second stage, coagulation factors and the platelet decrease. Now, so happen bleeding. Coagulation function decrease and happen bleeding. Now the second, during the secondary fibrinolytic stage, because fibrinolytic system is activated, plasmin increase, so lead to coagulation function decrease and happen bleeding. Now the last, during the last stage, secondary fibrinolytic stage, plasmin can hydrolyze fibril and fibrinogen, form fibrin or fibrinogen degradation, so production, so form FDP. It is called FDP. FDP function have anticoagulation function because it can impair the platelet aggregation. So FDP increase platelet count aggregation. Now it also can block fibril polymerization. So FDP increase. So now FDP increase now will lead to fibril can't form clot. So lead to coagulation function decrease and happen bleeding. Now it is what is the first manifestation of the DIC? Why happen this manifestation? Maybe long person, maybe short person. So you might remember the pathogenesis of bleeding of DIC. Why happen bleeding? No, take break. Now the next we will learn 3 D-dimer and 3 P test.
Only 2 students watch the video.
Now let's continue. 外国人在中国，在中国多好啊，安全。好 ，let's continue bleeding. Now the first manifestation is bleeding. Now because consume coagulation factors and platelet. The second, fibrinolytic system is activated. The last, form FDP. Fibrinogen fibrin degradation products, FDP. Now the next we will learn what is FDP under the test. Now, plasmin hydrolyzes fibrinogen or fibrin and become fragment. The fragment is called FDP. The fragment are called FDP, fibrinogen or fibrin degradation products. So FDP. But from the definition we know FDP produce FDP by one pathway or two pathway. Now, produce FDP must what increase? Plasmin increase. What situation plasmin increase? Fibrinolytic system is activated. Plasmin increase. Plasmin hydrolyze fibrinogen or fibrin and form fragment. The fragment is called FDP. So produce FDP by two pathways. First, plasmin hydrolyze fibrinogen form fragment. It called FDP. The second, plasmin hydrolyze fibrin form fragment. The fragment also called FDP. Now, the first, plasmin hydrolyze fibrinogen and form A, B, D, E, and so on. The fragment is called FDP. Now, it is the first pathway. Now, during the pathway, have coagulation system activated or no coagulation system activated? Have or no coagulation system? No coagulation system activated. Now, if coagulation system activated, plasminogen form plasmin. Understand? Coagulation system is activated, thrombin increase. Thrombin lead to fibrinogen form fibrin. So during the first pathway, no coagulation system activated. Only which system activated? Fibrinotic system activated. So the pathway fibrinotic system activated belong to first or secondary fibrinotic system activated? First or second? Now, I have explained what is first fibrinotic system activated, what is second. First, refer to no coagulation system activated, only fibrinotic system activated. Now, secondary, refer to first coagulation system activated, next lead to fibrinotic system activated is called secondary fibrinotic system activated, because first coagulation system activated, it is stimulated belong to second. So the first pathway, only fibrinotic system activated, it belong to first fibrinotic system activated. Now, the next. Now the second pathway, refer to plasmin. The second form FDP. The second pathway, refer to plasmin hydrolyzed fibrin. What form fibrin? Now, plasmin hydrolyzed fibrin and form fragment. The fragment include X, Y, D, E, and D-dimer. So the second pathway have D-dimer. First pathway, no D-dimer. Now the second pathway, fibrin. How form fibrin? Fibrinogen form fibrin. What lead to fibrinogen form fibrin? Thrombin. Now the second pathway, first which increase? Thrombin increase, and the next plasmin increase. So the second pathway, which system first stimulated, and the next which system stimulated? Now first coagulation system stimulated, so thrombin increase, and the next fibrinotic system stimulated, plasmin increase. Understand? So the second pathway, first coagulation system activated, and the next lead to fibrinotic system activated. So the second pathway, fibrinotic system activated, belong to a secondary fibrinotic system activated. So now if from the first pathway, the FDP, no D-dimer. Now from second pathway, produce FDP. Now the FDP have D-dimer. Now, if the patient blood have D-dimer, so we know from second pathway produce FDP. Understand? Now, if no D-dimer, from the first pathway produce D-dimer. Now, now during DIC, have D-dimer or no D-dimer? Now, DIC from the first pathway produce FDP, or during DIC, FDP increase. Now, the FDP from the first pathway or from the second pathway produce. First or second? The second pathway. Now, we know during DIC first, which C-term activated? Coagulation C-term activated. So, some being first increase, some being lead to fibrinogen form fibrin. And the next lead to fibrinotic C-term activated. So, plasmin increase. Now, plasmin hydrolyze fibrin and form FDP. The FDP have D-dimer. Now, so DIC, the patient blood have D-dimer. So if the patient blood have D-dimer, we know produce FDP from the first pathway. The patient fibrinotic C-term is secondary activated. It's secondary activated. Now, laboratory diagnosis, 3P test and D-dimer test. D-dimer test we have learned. Now, 3P test. What is 3P test? Plasma, plasmin, and pyrocoagulation test. Now, it can detect the FDP in the blood. Now, the patient with DIC appear positive reaction of 3P test. What is 3P test? FDP and fibrin can form a complex. The complex, it is dissolved. The complex can dissolve in blood. So you can see the complex or no? No, can't see. Can it dissolve in blood? Now, if the blood add in protein, the protein in the blood, protein can come back with FDP and form protein and FDP complex. So, which substance free? Fibrin. So, the patient blood will have a lot of fibrin. Now, a lot of fibrin can form clot. So, if the patient blood have FDP, now the blood add protein, so the blood next will what appear? Form clot. Now, so we know if the patient blood add protein and form clot, it called the 3P test positive. Form clot, it called the positive reaction. If no clot, it's negative reaction. Now, if 3P test positive reaction, we know the patient blood have a lot of FDP. So we know DIC patient blood, the test positive or negative? Positive, because DIC patient blood have a lot of FDP. So add protamine and form free fibrin and form clot. So the test positive, not negative. Now it is a 3P test because protamine can combine with FDP and lead to fibrin librate. So fibrin are free. Now it is 3P test. Now D-dimer test we have learned. It is an important index which reflects secondary fibrinolysis and diagnosis of DIC. Now it is the first pathway produce FDP. The pathway, no coagulation system activated, only fibrinolytic system activated. The second pathway, first coagulation system activated, and the next fibrinolytic system activated. So first form fibrin, and the next plasmin hydrolyze fibrin and form FDP. The fragment have D-dimer. Now DIC produce FDP from second pathway, and because DIC first etiology lead to coagulation function increase, coagulation system activated, so produce thrombin, and the next lead to fibrinolytic system activated, plasmin increase, so plasmin can hydrolyze fibrin and produce D-dimer. And now DIC belong to secondary fibrinolytic system activated. From second pathway produce fragment, produce FDP. Now it is DIC test, 3P test, and D-dimer test. Now it is the first manifestation of DIC. Now bleeding. Now from it we know DIC, it is secondary fibrinolytic system activated. Now the fragment have D-dimer. Now the second manifestation, DIC, the second manifestation, organ dysfunction. Why happen organ dysfunction? During the first stage, form microthrombus. Microthrombus can block the vessel. Now if block the heart vessel, so lead to heart ischemia, so produce ATP decrease, cardiac output, contractility decrease, so cardiac output decrease, and happen heart failure. Now if the vessel block the brain, so lead to brain ischemia and lead to brain failure. Now if block the kidney, so lead to kidney blood flow decrease and lead to GFR decrease and urine decrease and happen renal failure. Now if block the pulmonary vessel, so lead to the patient pulmonary failure, pulmonary refractory failure, hyperrefractory failure. So what lead to organ dysfunction during the DIC? Micro thrombus, because from micro thrombus. Sleepy. Now, the third manifestation, shock. Why DIC lead to shock? Now, today we will learn DIC lead to shock. Understand? Now, during the shock, we have learned shock lead to DIC. Now, relation of DIC and the shock. Shock lead to DIC, DIC lead to shock. It is similar to hyperkalemia lead to acidosis, hypokalemia lead to alkalosis, acidosis lead to hyperkalemia, alkalosis lead to hypokalemia. Now, it is outcome and cause. Now, today we learn DIC lead to shock. What is cause? What is outcome? DIC lead to shock. What is etiology? DIC etiology. It is outcome. Now, so you think why lead to DIC lead to shock? We have learned shock refer to which decrease ECBV decrease. Now, DIC lead to shock. You might explain DIC lead to ECBV decrease and lead to shock. Understand? So, you think why DIC lead to ECBV decrease? Now, DIC, how many stages? 3. First, hypercoagulable stage. During the stage, form micro thrombus. So during the hypercoagulable stage, form micro thrombus. Micro thrombus can block the vessel. Now block vessel, so lead to venous return decrease. Venous return decrease, cardiac output decrease, so ECBV decrease, tissue perfusion decrease, and hyper shock. Now it is the first. The second, during the hypocoagulable state, what happened? Bleeding. Now bleeding lead to blood volume decrease, so ECBV decrease, so hyper shock. Now, the third, we have learned during the DIC organ dysfunction. What organ dysfunction can lead to ECBV decrease? Heart failure. Now, because block the heart vessel, so lead to cardiac, now lead to ischemia of heart, produce AEP decrease, cardiac output decrease, so lead to ECBV decrease, so hyper tissue perfusion decrease, hyper shock. Now it is the third. Now the fourth. Now during the return decrease, cardiac output decrease. Now also lead to capillary permeability increase, which move out, plasma move out, blood volume decrease. So happen shock. Now the last FDP during the secondary fibrinolytic stage, FDP increase. Function. FDP have anticoagulation function. FDP also can enhance Peterman lead to vasodilation function. So lead to vasodilation more. So venous return decrease more. Cardiac output decrease more. ECBV decrease. So DIC happen shock. Now DIC lead to shock include how many pathologies? There 5. Now you matter remember. Now the 5 remember or not remember? First, 4 microthrombus. Second, bleeding. The third, heart failure. Cardiac output decrease. Now the fourth, Peterman and 5-HT increase. Capillary open mouth, capillary dilation, and plasma move out, permeability increase. The last, FDP enhance Peterman function. Complement system is during the coagulation and anticoagulation fibrinolytic system activity. The complement system also stimulated. So Peterman and 5-HT increase. Now it is DIC lead to shock. Now include 5 pathogenesis. Easy. You can remember in the class, not homework. Understand? Now maybe long question, maybe short question. Now you might remember DIC lead to shock. Now during the refractory stage of shock, we have learned. Now, shock lead to DIC. Why shock lead to DIC? You must explain. Shock lead to coagulation function increase. Now, DIC lead to shock. You must explain. DIC lead to ECBV decrease. Understand? Now, shock why lead to coagulation function increase? Now, during the refractory stage, plasma move out, viscosity increase. Now, tumor infection can damage VEC and release tissue factor, stimulate intrinsic coagulation pathway. Now can also damage VEC lead to collagen export. So stimulate lead to coagulation factor 12 stimulated. So lead to stimulate intrinsic coagulation pathway. So during the refractory stage, intrinsic coagulation pathway also stimulate viscosity increase. Now maybe hemolytic anemia, red blood cell platelet also release tissue factor. No? tissue factor-like factors. So it is shock lead to DIC. Now the two PPT you might remember. It is relation of shock and DIC. If I ask relation, now you might write DIC lead to shock and shock lead to DIC. The two pathogenesis you must write. You must both write. Understand? Now is the second manifestation shock. The last manifestation, macroangiopathic hemolytic anemia. Now during the DIC will lead to red blood cell break, and form histiocyte. Now, histiocyte refer to red blood cell break. Now, the fragment form irregular fragment, maybe like mole. Now, it is histiocyte. Now, why happen red blood cell break? Now, it's called MAHA, macroangiopathic hemolytic anemia. The anemia, red blood cell break. See, so it belongs to hemolytic. Now, why red blood cell break? During the DIC first coagulation system is activated. So in the vessel, now form a lot of fibrin net. Fibrin increase, so form a lot of fibrin net. So red blood cell adhered to the net. Now bloodstream impact the red blood cell, so lead to red blood cell break. Now, so hyperintensite and hemolysis. Now it is DIC manifestation. Now DIC manifestation include first, bleeding. Second, organ dysfunction. Third, shock. The last, hemolytic anemia. Now, MAHA. Now, DIC. Now, bleeding pathogenesis include three. First, consume. The second, fibrinolytic system activated. The last, produce FDP. Now, DIC, why lead to organ dysfunction? Because from microthrombus. Now, the last, DIC lead to shock, include five. Clot, bleeding, cardiac output, ketamine 5-HT increase, FDP enhance ketamine function. Now, it is DIC patient treatment. No one is okay. Now, exercise very easy. You can do it. Now, the 12. Produce exercise, consume, occur, overcompensatory. DIC occur relatively easy in obstetric accidents due to placenta. Now, disseminate placenta have a lot of tissue factor. So now tissue factor can stimulate coagulation. Now now during the pregnancy have hypercoagulable or hypocoagulable. Hypercoagulable. Hypercoagulable status, it is triggering factor of DIC because the pregnant woman hypercoagulable status, so easy happen DIC. Now placenta release tissue factor, it is etiology or triggering. Etiology, obstacle, complication. It is etiology, not triggering. Triggering, hypercoagulable status. Acute DIC. Now bleeding. Anemia called DIC is called easy BMH. Macroaudiopathetic hemolytic anemia. Now, red blood cell. Hydrolyze, macrothrombus, and fibrinogen. Understand? Plasmin, function of plasmin. It can't stimulate intrinsic and extrinsic coagulation pathway. Understand? Which can't lead to DIC? Last. It is anemia. Now it's very easy. Which cell? A red blood cell. Now it is DIC. Now decompensatory. Now hyperia can stimulate release TFPI. It can phagocytize and remove coagulation factors. Now dysfunction, so clean the function decrease. So can't remove or phagocytize coagulation factors. So lead to coagulation factor increase, coagulation function increase. Now it is DIC. Now during the PPT, the last have definition, have short portion and long portion. So during PPT, so you might do homework, you might remember. Understand? Now stress, the chapter very easy and less. You might remember definition of stress or stressor is okay. The other you know is okay. Not remember. Understand? So the chapter very easy. Now I explained your stress or stress response. What is stress? Non-specific response of the body to any stimuli is called stress or stress response. So non-specific response. What is specific response and non-specific response? Now, if birth, operation, infection, or hypoxia affect the body, now what will happen? Now, maybe happen tissue necrosis and hypoxia lead to acidosis. Understand? Now, it belongs to specific response. Now, if the substance affect the body, what also happen? Now, the patient anxiety, fear, heart rate increase, respiratory rate maybe increase. Now, the manifestation haven't directly relation with stimuli. Now, it is non-specific response. Now, the non-specific response is called stress. Now, we know any non-specific response to any stimuli. Now, it called stress. Now, etiology, stressor. Now, stimuli is called stressor. Now, stressor are the events or environmental agent responsible for initiating the stress response. Now, stressor include three types: external stressor, internal stressor, and psychosocial stressors. Include three. Now, external stressors include cold, now heat, temperature increase or decrease, hypoxia, toxin, drugs, bacteria. Now, it belongs to external stressor. Internal stressor maybe include imbalance of acid-base imbalance, now water and electrolyte disorder. Now, it belongs to internal stressor. Shock, organ dysfunction, organ failure. Now, this belongs to internal stressor. Now, psychosocial stressor. Now, complicated interpersonal relationship, inflation, competition, pressed work. Now, so if have exam, now you maybe can't sleep. Understand? Now, it is stress. Now, during the exam, your respiration increase, heart rate increase. Now, it is stress. Now, the stress, it is good or bad? No. If mild stress, it is good. Now, mild stress lead to catecholamine increase. Catecholamine increase. Now, if mild increase lead to cardiac contractility increase, now will lead to supply oxygen to tissue increase, supply to brain increase. Now, brain oxygen increase, so you can remember some. Now, so it is good. Now, if the stress very more, now you maybe forgot all. You can't write. Understand? So it is stress. Now, the same stressor on different body, the response different. Now, the same exam, some students stressor mild, some students no stress. Because the students can't write the paper, so no stress. Now, some students review not good, maybe stress because anxiety. Now it is stress. Now you know it's okay. You might remember definition. Stress or stressor is okay. Now you must remember. Now the answer, if you are interested in stress, you can learn by yourself. Understand? Now during the exam, you might remember definition stress or stressor. Now, okay 吧，class over 吧。The next class, you will learn heart failure. Heart failure.
Now you first review about contractility, systolic or diastolic. 还结束不了了呢。是吧？这